Welcome, everybody. Thanks for joining. Thanks for being on time. We're just going to give this one more minute just to let Zoom, let as many people from that initial registration join us as we can. Um, and then we're going to get started in a minute. In the meantime, if you want to chime in the chat, let us know who you are, where you're tuning in from, whose land you're on. Be wonderful. It'd be nice for our hosts, our panel to get a chance to meet you. So feel free to do that through the chat, and we'll get started. My name is Ari Maharaj. I use he, him pronouns. I'm the Outreach and Education Coordinator at the National Eating Disorder Information Center. I'm pleased to be one of the co-hosts for this webinar alongside JDRF Canada, and my colleague Amanda's going to get a chance to introduce herself in a second. But before we do that, I really wanted to do an important acknowledgement, knowing that for NEDIC and for JDRF, we support people all across the land presently colonially called Canada. For NEDIC, our in-person offices are located within Toronto on land described within the Dish with One Spoon, a treaty between the Anishinaabe and Haudenosaunee that bind them to share the territory and protect the land. Indigenous peoples of many nations have lived here for at least the last 15,000 years, and we are all treaty people. We just might not all know about our treaty obligations. For NEDIC colleagues who aren't Indigenous to this land, this acknowledgement is a reminder to appreciate and recognize how our relationship with the land, physically, mentally, emotionally, and spiritually, is interconnected with how people can experience disordered eating, diabetes, health, and access healthcare in general. And experiences of racism, of intergenerational trauma, of settler colonialism, of health inequity can have really powerful negative impacts on that health. For us, I think we have to start a conversation around the ways in which we support the patients and service users that we support with recognizing their inherent worth as they are, regardless of their relationship to health, and see health as an impermanent state of being. And the degree to which health is even attainable can really vary widely between individuals. We don't believe that being healthy or pursuing health is an obligation an individual owes to society, nor reflective of someone's value. But we think our job as healthcare providers is to do our best to support them anyway, in whatever goals that we have around supporting them and whatever goals they have around supporting them. We have a few resources that while Amanda speaks, I'll put some of these resources in the chat. There's some podcasts and blogs to listen to around the ways in which body image and eating we can think about more Indigenous worldviews in relation to that. Also, a resource that was co-written by Indigenous folks to share their experiences more in first person. And so if that's a resource for you or First Nations, Métis, Inuit clients that you have, feel free to share. But I'll share a little bit about NEDIC and hand it over to Amanda. We're a Canadian charity that's been helping people affected by eating disorders since 1985. We operate a national toll-free telephone helpline and online chat program in English, which provides support, information, and referrals to people supported or affected by eating disorders and those who care for them. You don't need a diagnosis to contact us. It's an confidential service and anybody can reach out. If it's a concern for you, it's a concern for us. We also do workshops like this, really focused on prevention and early intervention. A lot of our focus is with youth and healthcare providers and post-secondary campuses. But if you feel like you have more questions about NEDIC, you'll see my name pinned in the chat. And if you want to send me direct messages throughout this webinar or email nedic@uhn.ca, happy to have a chance to chat with you. But you will see me throughout this in the way that I'll moderate Q&A. But for now, I'll turn over to my colleague, Amanda.
Thanks, Ari. Hi, everyone. My name is Amanda Haleman, and I'm the National Manager of Mental Health Programs with JDRF Canada. And in addition to Ari, I'll be moderating this afternoon as a co-host from JDRF. So for those of you that aren't familiar with JDRF, we are the leading global organization that funds type 1 diabetes research. And the goal of our research is really to improve the lives of all people affected by T1D by accelerating progress on the most promising opportunities for curing, better treating, and preventing type 1 diabetes. So in late 2021, JDRF Canada launched its mental health strategy in an effort to fund both new research in the area of type 1 diabetes and mental health, but also to help close knowledge gaps among mental health providers and healthcare providers, and really to engage the type 1 diabetes community to increasingly bring mental health into everyday diabetes care, because we know this is a really big gap, especially in the Canadian healthcare system. Two of our big initiatives that we have, if you wanted to check them out, in collaboration with Diabetes Canada, is our mental health and diabetes training program. That's available at learn.jdrf.ca. And then we also have the Mental Health and Diabetes Directory, which is a directory of mental health providers that have actually gone through the training, that are accepting new patients, that have a baseline understanding of the impacts of mental health on type 1 diabetes. And that's available at directory.jdrf.ca. If you wanted to learn more about T1D and mental health, we have a section on our website under information for healthcare providers, including one document that's specifically related to recognizing disordered eating in people with T1D, which will be touched on a little bit in this presentation as well. So the chat is open for you to ask questions. Thanks so much for introducing yourselves. I've been seeing them come in. And if you do have any sort of tech questions, Ari is available, like you mentioned, to answer any questions. And if you have any comments, general questions for our panelists, please do populate them into the chat. If it does become super active, we might pause it just so we can catch up and make sure that we're not sort of overwhelmed. But you will also have the opportunity to sort of use the raise hand icon and verbally ask your question to our panelists, and we'll call on you. Please don't unmute yourself unless you're called upon. And the panel discussion will be recorded, and it will be available both on the JDRF YouTube channel and NEDIC as well. The format of this webinar is going to be a case study presentation. So we'll have two case studies, each about 20 minutes, that our panelists will walk through and explain, and then they'll kind of speak to each case from their different perspective. And we'll have a Q&A, an opportunity to ask questions about the case and engage with the case with our presenters and the folks that are attending here today. And then at the end, we'll also have some time for QA if there's something that we didn't get to. And if we do have a lot of questions, we are keeping track of them, and we'll do our best to kind of send a follow-up of any unanswered questions that we can kind of answer post-webinar. Just a reminder to everyone, please do whatever you need to take care of yourself during this event. We know that there might be some surprising or difficult emotions that come up. Like Ari already mentioned, he's available for a chat if you needed to send him a message. If you do live with type 1 diabetes yourself, make sure you have a snack or a juice handy, available for the next 90 minutes or so. Just one note on language. So the panelists and the moderators, myself and Ari, we're speaking from an I perspective. So this is really just not to make any assumptions about others' experiences. And the facilitators here and the moderators and panelists only represent their own perspectives. And we recognize that as much as we try to have a sort of comprehensive multidisciplinary approach, not all perspectives are captured here. And just to give an introduction to who's actually going to be speaking here today. So we have Silvana Sita, who is an assistant professor in the Department of Psychiatry and Neurosciences at the Faculty of Medicine of Laval University, and a researcher as well there. We have Anne-Sophie Brazeau, who's an assistant professor and the director of the Dietetics Education and Practice Program at McGill University School of Human Nutrition. We have Remy Rabassa-Lorette, who is an endocrinologist at the Montreal Clinical Research Institute, or IRCM, and the University of Montreal Hospital Centre, CHUM. He serves as the director of the Diabetes Clinic and the Metabolic Research Unit at IRCM, and he's a full professor at the University of Montreal. And we also have Aude Bandini, who's been living with type 1 diabetes since 1992, who has lived experience of type 1 diabetes as well as eating disorders. And she is a philosophy professor at the University of Montreal, a volunteer with JDRF Canada, as well as a patient partner in the Better Project. So without further ado, I'll hand it over to our panelists.
Thank you very much for all this presentation. And for, I would say, having served the table. So we are very pleased to be here today. And this is like the step two of first webinar we did a few months ago now, which was more about introducing the concept and the interrelation between eating disorder and the type 1 diabetes. So today it's more the idea to go more deeper in the concept, and this is going to be through two clinical cases. So that's for first, that's our conflict of interest. And our objectives are to recognize potential indicators of eating disorder, particularly across what we call unusual symptom presentation. And you will see that both clinical cases are quite unusual presentation. And we also try to illustrate the significance of adjusting clinical intervention in accordance with endocrine and eating behaviors. And also, we will try to underscore the importance of the transitional phases, especially from the young to adult and patient stigmatization. So first of all, a quick reminder, Anne-Sophie.
Sure. So since today we have people that are more from the mental health sphere, and some people are from the diabetes sphere, we wanted to just do a little overview of key concept about type 1 diabetes and eating disorder. So type 1 diabetes, just to remind, just a little reminder, that's the autoimmune form of diabetes. So that means that there is destruction of the cell that produce insulin, and so there's requirement for insulin admission daily, multiple time a day. It can be diagnosed at all ages, but about half of the cases or a bit more are diagnosed during childhood. Um, People will be required to do blood glucose monitoring, so to look after their blood glucose levels. As mentioned, insulin adjustment according to what they eat, the exercise, the stress. So there's a lot of factors that comes into the daily management of diabetes. It's 24 hours a day, 7 days a week, 365 days a year. So it's constant. And we want to make sure that we manage blood glucose levels to avoid as much as we can acute complications such as hypoglycemia or diabetic ketoacidosis, or also to avoid any or to postpone or delay the onset of chronic complication that can be high complication, kidney complication, nerves complication. And so all of that to say that type 1 diabetes requires a lot of self-management from the person that is living with, and it will impact the way they feel they feel some of their they may have different feelings for when they are hungry, feelings when they have hypoglycemia. And so we will discuss that today, but we need to understand type 1 diabetes to better understand eating disorder that are related to type 1 diabetes.
And I,
Anything to add?
no, I will say at contrario, we have to better understand eating disorder, disordered eating to better care with individuals living with type 1 diabetes. So just a quick overlook to the eating disorders continuum. A core symptom traditionally described for eating disorder is body image issue, meaning that your body image will excessively influence your self-image, self-esteem. And based on this symptom, we have, I will say, two sides of the spectrum. The first one, which is more about eating restriction, food restriction, and the more illustrative disorder is anorexia nervosa, which will lead to restraint from eating in order to decrease the calorie intake and to lose weight and more weight. And on the same aspect of the spectrum, we also have orthorexia, which is more about eating under the pressure of rigid law rules on what to eat and when to eat. And a more debilitated eating disorder is bulimia. Bulimia is the recurrences of binge eating episode, which will be followed by compensatory behavior, such as vomiting or taking laxative or diuretic. At the other hand of the spectrum, we will have more distributed eating disorder, which is, for one of the best examples, the binge eating disorder, which will be the recurrences of binge eating episode without any compensatory behavior. But in this part of the spectrum, we will also have some compulsive eating, meaning eating repeatedly or during the day, all day long, or grazing. And what we have to understand is that beyond the traditional, more described eating disorder that are anorexia, bulimia, or binge eating disorder, we have a full range of behaviors that can lead or conduct to suffering in people, in individuals. So that's what we call the disordered eating. That's more like I was, what did I just say, between the normal and the eating classical disorder. And this can include suffering or behavior such as frequent dieting or just like anxiety associated with specific food or meal, skipping, fasting, or purging to make up for bad food. Also, chronic weight fluctuation, rigid ritual surrounding food and exercise, like in orthorexia, but also intense feeling of guilt and shame associated with eating. Another very frequent disordered eating, especially in type 1 diabetes, will be the feeling of loss of control over food, which may lead to compulsive eating. And also, what is interesting is that currently in the actual literature, the warning sign of eating disorder are also described regarding or being specific of type 1 diabetes. And what we consider as non-specific are poor school or work performance, especially acute decrease in performance, trouble with interpersonal relationships, depressive symptoms, frequent dieting, laxative or diuretic use, self-induced vomiting, and excessive exercise. Traditionally, we also used to describe amenorrhea as part of eating disorder and anorexia nervosa definition, but nowadays we are this symptom is no more in the classification, but still relevant. So this is more like overall general symptom, but some are described as more specific of type 1 of eating disorder in individual with type 1 diabetes. And I mean that's a classical definition, and we can have a discussion around this because we are not so sure that are the best indicators, but that's the one which are the more described. And that's a poor adherence to blood glucose monitoring or insulin administration, the recurrent exercise-related hypoglycemia, the unexplained increase in glycated hemoglobin level, especially when it's quite of a very fast change. Also persistent hyperglycemia in the morning, and also repeated episode of diabetic ketoacidosis as a consequences of insulin privation. So this is what we are traditionally describing about a warning sign of eating disorder. But what we'll try to show you across our two different clinical cases is that sometimes the reality is very different. And for the first case, I would like to tell you about one of my patients. He was addressed to me in consultation for an eating disorder, referred in an eating disorder center. And this young man had in his personal psychiatric history one diagnosis of ADHD and no other psychiatric history. Regarding the medical condition, his type 1 diabetes was diagnosed at the age of 13. He had quite high number of hypoglycemia a few years ago, but seems be more stable, if you want to say like that, since a few years. But recently, he did a severe episode of diabetic ketoacidosis with an lead him to the emergency unit. Regarding his habits, he do not consume any alcohol, and which is very interesting is that he told me that he avoid to consume any alcohol because he was too anxious to deal with alcohol calorie and insulin compensation. He did not take any coffee, tea, or energy drinks. He used to take some more recreative drugs like cocaine or amphetamine, but not since a few years now. So, regarding the type 1 diabetes history, he told me that it was quite a complicated diagnosis. The time was very difficult for him. The diabetes was very unstable at the first time. And he could explain me that his mother supported him a lot and was kind of very supportive, meaning taking care of a big part of the diabetic care. And currently he's using a CGM, a continuous glucose monitoring, and an insulin pump. He is very comfortable with the use of the equipment, no anxiety regarding this, but regarding the bolus injection, he cannot do any injection in the bolus. And when it comes to correct hypoglycemia, the fear comes and he reach, I would say, very high number of glucose, carbohydrate, in for the compensation up to 100 grams from juice and do not take any protein or cannot deal with all the rules, injunctions, will I say, that the dietitian gave to him. And this is an extract of his CGM, and we can see that the estimate glycated hemoglobin is around 10% and is more than 90% time above his target. So he's really trying to avoid any hypoglycemia. Regarding nutritional aspect, what I found is it was very disorganized, no specific hours to eat, and what appeared to me is that all was about anxieties. Everything was worrying him. He cannot take any glucid or carbohydrate from his diet because he was afraid of having to inject insulin or to compensate the blood increase. He explained also that he has lost all sense of appetite, and which is also interesting is that, and remember I told you that in classical definition of eating disorder, body shape is a core symptom. I mean, he would like to gain weight because he lost a few pounds during the recent ketoacidosis episode, but he cannot do that. He feel it's very difficult for him to gain weight. And he do not describe any loss of control over eating. I mean, it's more about restriction, but he also experiments many cravings, but it's still relevant, but less frequent than it used to be. And this craving especially appear after smoking cessation a few years ago. And regarding mental assessment, he arrived, I think, like more than a half an hour earlier of his appointment. It was kind of very stressful. He easily discussed his emotional experiences and the connection he make internally. I mean, he's quite smart guy, trying to understand what he was living and going through. His speech was completely coherent and appropriate, but most of the speech was around the fear of hypoglycemia. Affects were hygienic, anxious, not blunted, quite normal affects. He described having had panic attacks a few times before, and he had and still have this strong fear that this panic attack comes back again. And which worried me a little, I would say more as a psychiatrist, that recently he started to develop some obsessive and compulsive elements. I mean, he he avoid to change the color of his sweater due to the fear that will disrupt his diabetes. And he knows that was completely the crazy, and that was used as a term, but cannot avoid this feeling or thought. And this is really a symptom of compulsive disorder. And other aspects, sleep, etc., everything was good. It was really about anxiety. Um,
Before we go to the panel,
yeah.
Ari put in the chat that you had to Google what is ultimate means.
Yeah,
Um,
actually, that's true.
so maybe you want to explain?
Yeah, sorry, that's kind of, a psychiatric word. We love speaking another language in order nobody can understand us. I mean, ultiming means that the mood is correct, is normal. It's not sad, not joy. Having a normal mood with ability to experiment different affect, different state of mood. So this means everything was good regarding the mood aspect. Is that correct? So, I mean, this Mr. Health was addressed to me for an eating disorder. I mean, but as you may have already perceived, he was not really about a classical usual eating disorder. I mean, it's not an anorexia nervosa, obviously. It's not a bulimia nervosa, but we can also perceive that there is a high degree of suffering from eating. So I will ask to my colleague, what do they think can happen for Mr. Hills? And if you have any suggestion in the chat, or feel free.
So maybe in the chat they can put what seems to be very striking to them or
Yeah,
surprising about this case. And we can definitely discuss it, the
Let,
four of
let
us.
me start, Silva, and try to play the all grumpy doctor focused exclusively on glucose. As you say, as you know, I am like this. So, is it an eating disorder, or is it only a non-compliant patient with which have some kind of eating behaviors with no relationship, no direct relationship, actually? Maybe we could say he just have to take his insulin, right dose, and everything is going to be okay. And I'm voluntarily provocative for the ones who don't know me.
I mean, what's a non-compliant patient? What you say? This
Yes,
doesn't exist.
non-compliant patient, yes, non-adherent patient. He just needs to take his treatment at the right dose.
Yeah, I mean, the first answer for me is he rise up to my consultation. I mean, he wait to see me. He came on time, before time. So I mean, he's a compliant patient. He's trying to get help. So you can just answer that.
I love your answer. So, but my point to the people listening is that in a lot of teams, he
Mm.
would be labeled as a patient that is not taking his treatment in the right way, and that would be the only main conclusion of the medical note. So I like the fact that the endo team here thought there was something else behind.
But truly, Remy, you address what is a main concern for me, and I think for all of us here. It's the same thing for eating disorder. How many times I heard that, patients suffering from anorexia nervosa don't want to be cured, don't want to be treated, are non-compliant to treatment, etc. But truly, we do not have a very efficient care in anorexia nervosa. We can say that. I mean, by efficient, I mean right one pills solution. And, patient came to our consultation, try to involve, and what we have to do is to go behind first appearances and to find the way to address the difficulties, the resistance, if we call them like that, in order to care of our patients. So it's the same thing for diabetes. I mean, no, it's quite easy to say, okay, just take protein in your collation and you will deal with your fear of hypoglycemia. it will help you not to have a secondary decrease. But it really is not the case here. And we can see for Mr. S, it's more about anxiety and fear.
Yes, there's actually a lot of question in the chat, the comments about addressing fear of hypoglycemia as a first step.
And we have someone who rose her hand. I think Sylvia.
Yes, Sylvia, please go ahead.
Yes, what also stood out for me, and that really works into what the provocative doctor just said, is a statement of he can't gain weight. That really builds into, oh, just take his medication and the biology will work itself out. When in fact, I specialize in eating disorder. I'm a dietitian and also a therapist. And so when I hear that statement, I hear the medical emphasis as a solution. But I also put my mental health hat on and say, what do you mean by he can't? If we look at it from a mental health perspective, then we get a deeper sense of the can't. Is this a mental health barrier can't, or is it only a physiological issue?
Yeah, that's a good question. And I do not, in
I
this
would think
case,
it's both,
yeah,
Sylvain, in this case, because like the fact that this person is in hyperglycemia most of the time, clearly losing glucose in his urine, like it's a difficulty to gain weight when you're in a catabolic state like that. So
For
of
sure.
course, but you've been talking about the fact that he fear of eating certain quantity of foods, certain carbs. So I think we are really playing on both sides in this case.
yeah,
For
and
sure.
in the same time, it doesn't feel any hunger feeling. So it's difficult to estimate all you have to eat when you do not have any sensation to help you to guide you. And also, there is kind of, and maybe Remy will help me to answer this question, but there is also quite an ambiguity. This patient have a lower weight and try to gain weight, but at the contrary, how many times we can hear that gaining weight in diabetes, it's also getting insulin resistance and meaning also taking the risk to needing to need more and more insulin. So it can also be normally frightening process or aspect, even if it's not an eating disorder, it's not a body concern, it's also a health concern. So
I fully agree. We should
Yeah,
not stigmatize overweight and obesity, but at the same time, we need to acknowledge that it can aggravate some other health problems or add problems to type 1 diabetes. And as you alluded, so we need to acknowledge that type 1 diabetes is bringing so much nutritional issues like carbohydrate counting, which is mainstream and probably for some good reasons, but in the context of eating disorder, it can be a huge problem. You need to think to your insulin dose every time you eat. There is hypoglycemia with all what it can bring as fear for that patient, but also the need to eat frequently, to take snacks multiple times, even when you're not hungry. Or on the opposite, hypoglycemia can trigger some huge hunger aspects in patient. A patient frequently tell me that she would kill to get food when she's in hypoglycemia. And yes, there is a trend of weight gain that we obviously see. For example, in our registry, we clearly see that around 40% of people living with type 1 and are overweight and 20% facing obesity. And again, we no stigmatization, but it can aggravate problems like hypertension and some other issues. So it's a double-edged sword, which is not always very easy to manage because You don't want to put this up front, but at the same time, it can complexify some of the management of type 1 diabetes. And I'm speaking here for the patient every day. A thing that patients speak of very frequently, higher insulin dose with gaining weight, and there is a big thinking in a lot of patients that more insulin is not good. That's meaning that their health is not good, because there is kind of feeling that the more you need, the more you're sick. It's not fully true, but we need to acknowledge that this is the case for a lot of persons living with type 1.
Yeah, if I may, what strikes me in that case description is the
If some people that
yeah.
could mute their mic, it would be really appreciated. Please. Thank you.
It's the coexistence between two character traits, which are a need of control that is expressed in the somehow irrational control that changing his sweater color could affect his blood glucose levels, and as well willing to avoid alcohol at all cost in case it may affect his glycemia as well. And on the other hand, some thing that is suggestive of a lot of control when he correct a hypo with 100 grams of uh, sugary drinks or whatever. And I think that I'd love to have your opinion about that. But my feeling is that a lot of things in type 1 diabetes are about control because you have to control nearly everything. And sometimes, and I'm just speaking from my own experience here, is that you invest so much energy in control that when something goes wrong and you fail, you feel like a total failure. And since it's going bananas, let's, you know, and I'll get back to it tomorrow or not. But perhaps there is a question of balance between the amount of control that you are feeling obligated to stick with and sometimes the need for relief and, not to worry that much and so forth. And I guess that one may lead to the other, which is too much control for a certain range of time might get you to the wall and you will definitely crash.
Yeah.
I think you put words on the difficulties of living with diabetes.
Yeah, I heard about living with type 1 diabetes of
Mhm.
40 last years.
I think everyone should hear a bit more so we can understand, like, we will be better at understanding our patient if we had experienced that just once. The fact that it's constant, it's all the time, and sometimes you need a break, but you don't have any break. And it will interfere with mental health. It will interfere with diabetes management. It will interfere
Well, I
everywhere.
guess for any both physical and mental health provider,
Mm.
there are personal experiences on which you can build, which is, I don't know, try to stick with a given routine, go to the gym or um, take care of a minor issue and you have to take a treatment even though you don't feel ill or whatever. It's very hard. You have to think about it. You have to actually do it, even when you don't feel like doing it. So I don't think that it is so strange or alien to all of us. Just keep in mind for you healthcare providers, please keep in mind that we are human.
I'm
If
seeing
yeah,
something in the chat. Oh, go ahead on Sophie, and then I'll ask a question I'm getting from the chat.
I was going to say that, like, a lot of people in the chat have said, like, we should address the fear of hypoglycemia.
Yeah.
And I think it's interesting that this patient was referred by the diabetes team to the psychiatrist for an eating disorder. And now we are discussing back to the fact that fear of hypoglycemia might be a key element. And so that's also speaks about the importance of having a global view on what the patient is experiencing. And so I was going to ask Sylvain what he thinks about like addressing the sphere of hypoglycemia as something like first line.
Yeah, that's very interesting because I think one of the traits in this clinical case is to fully understand the situation. I mean, Mr. S was kind of children that grew up very fast, and you spoke about control ode, and he was kind giving a part of the control to his mother. And as an adult, he did not have access anymore to this reassurance way to his mother as a contraphobic, will I say, tools. And was just having to face to himself. And speaking of this hypoglycemia, I mean, and one question in the chat was about going to explore when the fear starts, and that's very important because in this case, the fear of hypoglycemia starts in the same period he had to face a panic attack. I mean, both were at the same time for different reasons, and he kind of memorized both together. So as soon as blood glucose variation appear, the fear of an panic attack recidivism appear, and as soon as anxiety rise, grow up, his fear of having an hypoglycemia increase too. I mean, and I don't know by which hand we should start the care, but you have to address both. And in my case, as a psychiatrist, I mean, I start by anxiety, overall anxiety, because you also have more generalized anxiety and this OCD symptom, obsessive compulsive disorder symptoms that appear. So, I mean, I was more comfortable to start by treating anxiety, but indeed, going in a deep comprehension, in a true discussion with the patient is the best way to find, um, I mean, say the best treatment option, will I say? And you have to really have this discussion with this patient. You cannot choose for them.
Yeah, I like Sylvain noting that even the focus on anxiety. We have someone in the chat, Caroline, noting as diabetes educators, I think we're sometimes so trained to focus on hypoglycemia related issues that we might be tempted to focus on that fear to the exclusion of other potential issues like control, like Ode mentioned, or the food restriction, like the avoiding carbs to reduce insulin needs and therefore maybe injection frequency. So yeah, I appreciate the linked conversation that we're having here and the comments in the chat. Uh, There are two folks who raised their hand. So
Yeah,
Sylvia, I'm gonna go to you and then Natalie. I'll put you on spotlight and then we'll have some final comments about this case before going on to case two.
yeah.
So Sylvia, let me go ahead.
I was just I want to 100% agree with Sylvain, and I think it was Audie because we are not just looking at um, a symptom or a disease. We're looking at a whole person. And so by the time that the person comes to you, and I think this person were showing symptoms, they were a while before they actually got diagnosed. That person then, and even, months and years later, they're dealing with a whole myriad of life. And I think the idea of looking at really analyzing control is not only about the diabetes itself, but it's life in general. So I really, really like that larger, looking at that person as a holistic person who comes with all the challenges of life in addition to or as a result of or emphasized by the diabetes and the need for tight control or else. sort of a thing. So that's really, I mean, again, remember, I'm also a dietitian, so I'm not ignoring the physical health piece, but so often that mental health piece gets lost. And I'm going to keep coming back to that, and I'm sure Sylvain will help me with that. Thank you.
Thanks, Sylvia. Panel, anything you want to say in response to that before we go to Natalie?
I think we can also highlight in this case the age of our young men, 24. So
Mm.
it's also a young man that just transition from pediatric care to adult care. He had his severe hypos when he was 18, 19, and so there's a life trajectory here that I think we need to take into account in this case as well. Um, and we didn't emphasize that too much in our discussion, but I think it's also important when we're trying to understand this young man. That's just what I wanted to add.
Thanks, Anne-Sophie. Go ahead, Natalie.
Yes, thank you. I was just thinking that I think is it Ode? Ode? Am I pronouncing it Ode? You mentioned around that kind of dialectic of the need for control but need for surrendering. I'm also a type 1, so I get that. But something that was coming to mind um, about supporting a young man like this is what seemed really cool to me is he really does have that sense of needing to control, yet at the same time he has this ability to rely on an insulin pump and a CGM, which we may not see in some people who are really, really fixated on that control. I've noticed that there's some folks who may not even trust it, and they think, well, I know better, right? So that might almost be an entry point to control to explore with him is, there is this need for control, and there's this ability that you have to be able to kind of trust your medical team and their suggestions, or trust the technology. So that might be one thing I might lean into as well, to really just kind of bolster up the strengths that he does have, and ways that part of him being able to control things is also surrendering and allowing the what the recommendations have been for his treatment as well.
Sylvain, may I ask, in the interest of the audience, is the fact that he is a male typical or atypical? Can you comment a bit on this? There's a higher prevalence of eating disorders. We admit that he has some eating disorder in women usually.
I mean, I'm not convinced he had an eating disorder. Maybe a disordered eating, and not classically. Usually, the sex ratio is higher in women than men for I mean almost all eating disorder, with a higher sex ratio prevalence for women in anorexia nervosa, and this quite smaller sex ratio difference for binge eating disorder. But eating disorder are more frequent in women. And I will say also they are more frequently diagnosed in women. And we have to keep in mind that even if more frequent in women, not only women can suffer from eating disorder. I mean, and maybe to conclude, because I know time is going, uh, and regarding the psychiatry diagnostic, it was more about, regarding my diagnosis, I mean, more about a specific phobia, fear of hypoglycemia. I will say non-specified anxiety disorder, beginning of obsessive compulsive disorder, which was more wondering me, and also ADHD. And what I did, the first thing was to allow him to breathe a little, giving back this application with a D that can allow you to permit to a close one to follow your glycemia. So he did so with his mother, and we named that was not the best solution, but it was a good way to breathe a little. And so we did that. Also, a lot of psychoeducation about panic attack. You don't die in a panic attack, you survive, and trying to also explain how the symptom of hypoglycemia can be the same than the anxiety, and you have to learn how to make the difference if possible, because it's not always possible also to say that. And also, what I did was just to introduce some sertraline, which is an antidepressant that can really help for anxiety and OCD. And honestly, it was really efficient and very helpful for him because he can regain take control, even if I hate the control term, but regain some control in his overall life by decreasing the main level of anxiety and being able to deal again with this fear and helping to be more in his with his diabetes, if you can say that. So that was my intervention for this patient. So you mean it's not really about, for me, eating disorder as classical definition of eating disorder, but real preoccupation and suffering from eating we have to take care of. So we can go to the next case. Remy.
Yes. Okay. So let's discuss another unusual situation. If you can, am I allowed to move the slide?
I think yes, you are.
I am. Okay. Sorry, I missed.
Can you try?
Let me check this. No, it doesn't seem I am able to
Okay,
move the slides.
I will
If you
do the
can,
job.
please, Sylvain. Thank you. Um, so it's the case of a woman who was referred to me not very long ago, a few months. She's in the end of her 40s, and she's transferred by a colleague. And from the beginning, it's a bit difficult because I know that colleague follow a lot of patients with type 1, and usually I don't have referral for type patients living with type 1 from that colleague. So, but it's request for transfer, and we take it. So she's been living for diabetes for a long, not a few decades. She have a very small retinopathy and a very small microalbuminuria. It's better to have none of these, but it's not major complication. All of this, we know now that we can control them. She have epilepsy now for more than 3 decades. This can be intricated with type 1 diabetes, specifically when there has been history of repeated severe hypoglycemia. But this was not the case here. No alcohol, no tobacco. She is very exuberant from the first meeting, and she tell me that she walks every day 10,000 steps a day, and then she monitored this on the top of monitoring her glucose levels. Next slide, please, Sylvain. Never had any severe hypoglycemia or ketoacidosis. She used a CGM with alarm. And for our colleagues coming from the eating disorder, now in the type 1 diabetes world, at least in the one that have access to a few information, it's around 2/3 of people that use a continuous glucose monitoring, which can, at the beginning, trigger some eating disorders, or at least concern about food when you can see the wings, the fluctuation of glucose. But usually a lot of patients after a few days believe that there's far more advantages than disadvantages around having a continuous glucose monitoring. It's a little device who measure glucose under the skin. You maybe have seen frequently worn on the arm, but not always. She's using multiple injections, so that usually means 4 injections a day. When you have a patient for the first time, whether it's a transfer from the pediatric world or a transfer from another colleague, it's always good to have a few questions about basic knowledge, not to judge the patient, but just to assess, not to estimate that she, because she is living for decades with diabetes, knows everything about diabetes. At the same time, we absolutely need to acknowledge that the patient knowledge is sometimes far higher than ours. So there is kind of a yin and yang here to manage in a first appointment. She is really very exuberant. She speaks a lot. And she live a little stone that I neglected at the beginning, but I took it in my note. She said, by the way, I recently had to redo all my teeth because of type 1 diabetes. She actually mentioned that she had to take she had to take money from the bank for that, and that she's now having a very significant debt. And she's telling me that she's happy about the transfer, but still not very clear for me why she was transferred. Her most recent labs are exactly what you would await based on her medical history. Her blood pressure is correct. Her BMI is there. She still mentioned that she had a lot of judgments about her weight during her history, starting from the pediatric, that she should not gain weight with years, that's bad. Next slide, please. And here is her glucose profile. We are at the opposite of the case presented by Sylvain. Everything is absolutely perfect. No hypoglycemia, 87% time in range. For those who are not aware of this, we are aiming for above 70%, and 1% of the time is 15 minutes from a day. So this is what, oh my God. I'm the happy endo. I just got a very easy patient to follow. A1C is good. She is happy to be with me. Everything is good. So I congratulate her about everything, and we manage for the next appointment. And she leave my office relatively happy. I'm a strange doctor. I'm giving my email to patients. I'm following some from very remote location. And the next morning, I have 3 emails. So I said, oh my God, I'm going to have to do teaching about how and when to use email with me. But in all those emails, she's asking for semaglutide, also known as Ozempic, to help her to manage her diabetes. And there's a big, specifically in the social media, there's a lot of things around Ozempic. There is also maybe a space for Ozempic for some people living with type 1, though most of insurance, public or private, would not acknowledge for this. So rather than to start what I call the ping pong email, I propose a rapid new appointment, far better a few weeks rather than a few months after I met her. And there, she's not the same person. I saw her 3 weeks ago and she was exuberant and happy. And there she seems to be extremely uncomfortable. And so I come back in a little stone that I completely neglected at the first thing because I read back my notes. I said, what about speaking about the thieves? And she said, actually, I am a master of controlling my glucose with bulimia and vomiting. Actually, I lost all my teeth because I am vomiting 3 or 4 times a year. And I know exactly when to vomit and how much insulin to do based on what I'm going to vomit to keep a perfectly normal blood sugar. So she have binge eating, she then vomit. There's obvious anxiety there. So it's kind of Dr. Jekyll and Mr. Hyde. The thing completely changed. And then the question that I didn't have exactly the good answer at the beginning, because I also asked, say, well, cool, why have you changed? She said that she tried to discuss this issue multiple times with her team, but that she was always considered as the perfect patient because the blood pressure, the glucose control, the lipids, and so on were all in good order. So that is the main focus of diabetes treatment. It should be not only the only focus. So we are having a perfectly normal or optimal blood glucose control in the context of bulimia and vomiting in that patient, which was I completely neglected at the beginning. I mean, she didn't disclose it neither, but you probably understand that getting to a new team, it's not very easy to come and raise the flag and say, oh, by the way, I have a major eating disorder and I'm not the good patient. So that you seems to see in front of you, and don't take me by the word, there is no good and bad patients, and so on. So it was a completely different patient after a few weeks. And because of that email, and actually she told me that because she came back home and started to have a big bulimia, eruptus, and then vomiting, she decided that she would need to write me. But actually in the email, there was nothing about eating disorder. There was something about Ozempic that might be able to help her. Okay, Sylvain, so let's maybe discuss about this another unusual case.
And maybe we can do the same as before. If anyone in the chat want to put whatever they find striking about this case, feel free to comment. Um, for me, I think what was interesting is that we often in the diabetes world we often focus on glucose management, and this is eye-opening case where we need to go beyond those glucose numbers. Um, and I think, Remy, the way you invited her to reach out to you, you kind of give her room for her to express herself. And you went beyond the number, not necessarily during the medical appointment, but you gave her room to go there with you. And I think this is it's a really interesting case.
Yes, it's kind of below the surface. The surface, everything was going fine, but it's a bit like the little duck analogy. Beyond there is a lot of. I must say that I remember some of her words. Sorry, most of you have four different French accents. It's probably hard for the Anglophone here tonight, but words and not world. She was speaking about feeling guilty and also about the pain she had. She was suffering from that problem. So she was really looking relieved that at least she was able to address it in a context of a new team. And I believe sometimes it's good that a patient change team. It's not always easy, but sometimes it allow a new start.
And this is, especially and very important because to create a secure space is sometimes difficult for us. And I mean, even if everything is perfect, you can just say, okay, do not speak of anything else. That's sometimes the message we can involuntarily send to the patient. And I mean, you reach to create a secure enough space in order to send you email on the next day and to allow her just to say, okay, everything is not perfect. And I think this is very important for us as a physician or a dietitian or any health practitioner, just let a space for the patient to say, okay, have you anything difficult to face that we did not address? Have you any things that bore you during your day long or anything you want to speak we didn't address today? And I always finish my consultation by this. I mean, sometimes you think we have go through all the things that are important for you. And you can take 5 minutes more to speak of that or replan a new appointment. And this is very important.
And
And
actually, you're speaking about the end of the consultation, but I believe it also started at the beginning of the consultation when you ask a patient, "How are you?"
Yeah.
You need to take time to listen to the answer. It's not only a way to say hello. You really need to say this. When I see younger resident, as people can see, I'm not anymore a young physician. They all very good on diabetes management in terms of technique. They are really well trained. But having known how are you and taking time to listen and also understanding that judgment have never helped anyone in any case, far beyond eating disorders. So rather than to say this is not working, it's why is this not working should be is usually a better way to address this. So the way we approach those consultation is important. But I must say that a lot of my endo colleagues find that I'm a very inefficient doctor because I take too much time with the patient. So
Yeah.
that's my reputation in my field.
Yeah, but Remy, indeed, it should be at the beginning of each consultation, but truly, we need time to create a strong relationship with our patient, and it takes time. It's really frequent in my consultation. I have 1.5 hours per patient. I mean, my consultations are very long, and it's very frequent that at the very end of the consultation, this symptom right up. It's oh
So
about that doctor, and here again, and that's the time patient need to feel secure enough.
So let me try to jump on one question I just say so in the chat, which is related to this. Should we screen for everyone for eating disorder? I will slightly change the question. Should we weight everyone? If you look to Diabetes Canada or Obesity Canada, weight and waist circumference are considered as vital signs, and a vital sign probably should be taken. So how you see this? Should we screen for it? Is there a good thing that we could screen and discover some as underestimated cases, or are we going by this way to create at the same time some problems? And again, I'm using a bit provocative vocabulary here. Yes, oh, sorry.
Yeah, well, for a long time, that's what my endo team used to do. Blood pressure, readings of glucose levels, and weight. And I used to starve myself for over a week before every appointment because I knew that I was going to be weighted at my appointment. So I would say no. Because it may put a lot of stress on the shoulders of the patient, and that's something else I wanted to mention. Um, what strikes me in the case you described was how much courage it took for that person to be open with you, even though she was not able to talk about that at the very first encounter. But well, you are in an appointment about diabetes, not about mental health. And we are so used to have people in the diabetes world not really knowledgeable, neither comfortable with addressing mental distress. That in the setting of I want to be a good patient, I want my diabetes care team to like me, so I will put the better face I can, especially on the first appointment, and living with especially, I guess, with bulimia rather than perhaps orthorexia or anorexia. Um, Overeating is somehow the worst you can do when you live with type 1 diabetes. So it's very shameful because you know that you are hurting yourself very badly, even if in that case the person was able to make up for the glucose intake. But I mean, she lost her teeth, all of them. And one question I was wondering while listening to you, Remy, was did she come up with the diagnosis of bulimia by herself, or did her dentist mention that? Because I get that perhaps the dentist may have seen a red flag there.
So you gave me a good occasion to see something that wasn't that case, but that we see frequently. The dentists say that she lost her teeth because of type 1 diabetes. You can have gingivitis, very severe sometimes in diabetes. So there's a tendency because the type 1, I mean, all the form of diabetes, but we're speaking type 1 here, can potentially damage everything from the toes to the hair. There is an over tendency in the medical community to say, "Oh, this is about your diabetes," and roughly every half day, I intervene with a patient. I say, at least based on my experience, I don't believe type 1 diabetes is there. You can have two diseases at the same time. Unfortunately, you can do this. So that's a no. The dentist, I asked the question, and the dentist did not raise anything. She said she said she did a great work and took a lot of money for that. Which doesn't mean the dentist was not good, but she's worried. She have a debt at the bank now, so it's an important thing for
I'm
her.
just gonna unmute really quickly to say that Remy's also answered the question that we got around should a check for eating disorders be a part of every visit? Partly he did that out loud, but he also added in the chat just for the recording for people who won't see the chat. He says maybe ask for permission about measuring weight or speak about an eating disorder. And at least to us in the eating disorder space, something that we've especially been thinking of recommending more and more when a semaglutide or Ozempic is being part of a conversation is as part of that conversation about that medication. Potentially, that's a nice hint to say, let's screen for an eating disorder at that point. And like that might be a potential means
Uh,
for.
yeah,
Go ahead.
and why having and why having semaglutide is so important for you right now? What's the urgence to get this medication? And to answer to the question, I try to never wait my patient. I have no scale in my office, but it's quite easy because part of the hospital, some other do it for me. But I mean, I try to avoid any waiting, and moreover, I will say I try to avoid any comment about weight or shape variation in my professional or personal life. I mean, if you try to comment the weight of anyone around me, it will be a quite hard time for you. And it's very important, but I'm very welcoming any comment from the patient about his or her weight variation. I mean, if it's a concern for the patient, it's a concern for me. If it's not a concern for the patient, I don't want to address such a subject. But I'm a psychiatrist. It's maybe easier for me than for the endocrinologist, but just, I mean, just think, is it really a need this day to weight my patient or to speak about weight variation right now? Do I really need that for my on medical purpose? I mean, and regarding the screening of eating disorder, I mean, yes, should be part of every initial clinical assessment, I will say. And um, uh, maybe not saying, are you suffering from anorexia nervosa? I mean, there is other way to ask the question. And have you any concern regarding your eating habit? Are you suffering from your relation to food or to eating habit? No, this type of question are quite open and maybe very successful to offer a good opportunity for the patient just to.
Maybe we can add that like prevalence of disordered eating behaviors or eating disorders are higher in type 1 diabetes
Yeah.
than in the general population. So there is definitely a need or indication to try to screen for that. Um, that's one thing. And the other thing I was going to add is just like we said before, yes, we often tend to say that it's more women, but we also see a good number of men. And potentially there's more, but they weren't screened for. So just to stay aware.
I'm going to read this comment from Lauren in the chat to see if the panel has thoughts on it. Lauren notes, I see so many challenges for this person as they work on their recovery journey. Once they reduce/stop purging, their glucose levels will likely be all over the place, as the binging will likely still be present, even if reduced, and they will no longer be the perfect patient. This will likely cause or contribute to a lot of distress, which could increase eating disorder behaviors. Any thoughts on that as a panel?
Actually, that patient is now worried about gaining weight because she said, yes, I might be able to control better my bulimia, but will I gain weight? And this
And
referred to some of the comments she had in the past about the importance of not gaining weight from her pediatric follow-up, I guess, plus the social pressure and so on all around.
yeah, and again, gaining weight is also really part of the diagnosis of eating disorder. And this also answers to a question in the chat. Is it, in this case, an eating disorder, or this is a specific eating disorder of type 1 diabetes? And uh, I think that's challenging because the most validated tool for to treat eating disorder is the cognitive behavioral therapy from Fairburn, and in this therapy we will ask patients to eat every 4 hours. And this is very difficult when you're suffering or living with a type 1 diabetes. I mean, this is this. I'm just thinking that it's imply getting more insulin compensation. As how will I deal with my collation? Which type of collation of food intake? And our current program for eating disorder are not, I think, adapt to type 1 diabetes. But at the contrary, focusing only on kind of specific, very different eating disorder may also, you know, uh, may also be challenging, or maybe another because we will miss all the transdiagnostic aspect of eating disorder. So yes, we have really to build
So,
some program and culture.
Sylvain, it might be the time to speak about how diabetes technology might help some of those patients, either the one you presented or the one I presented, because this is a huge change in diabetes management over the last decade. We had all those continuous glucose monitoring devices, which are used by far more than 50% of the patient, approximately two-thirds in Canada. The problem is that the numbers coming from various sources are not very coherent, but probably around two-thirds of the patient using it and more well reimbursed. But there is also those new pumps that are able to speak to those sensors and adjust in part insulin. So from the endocrinologist's point of view, it is less hypo, it is less hyper, and some less burden. Doesn't mean that the burden is not there anymore, but there is a reduction of burden, which remain quite high. What is the point of view of maybe you, Sylvain, and Aude around what those diabetes technology can help, or can they relieve some of the eating disorders?
That's very difficult to answer. I mean, there is no one size fit all solution. We have really to have this discussion, and that's the same case for the first patient with our cohort. I mean, this type of system may be very helpful. I believe so, but we uh, we still need to explore that. I think, and Sophie is maybe the best to answer this question because we are studying this. You are studying it's a lot, but with Remy. But truly, it can help to decrease the cognitive load and the anxiety related to diabetes life or life with diabetes. But it also can be sometimes uh, very anxious to just give the control to a tool. I mean, it's kind of artificial intelligence based mechanism. We don't know what occur inside this. We cannot take easily the control back. So it can also be frightening.
Any
Some patients
final?
actually describe that with less glucose fluctuation, they have also less mood and less appetite or triggering their intention to eat, hunger, or how you say that, feeling full is modified. I don't believe there is good literature on this, but I have heard this on a regular basis, and I
And
believe I
and we are starting
yeah
to look at it, and what we see is that people using those automated insulin device seems to have more dis inhibition towards what they are eating. They are less restrictive as well. So we do tend to see a shift in the relationship with food when we start technology. So I think we need to work with the patient when they start this technology to make them comfortable with it. And as dietitian, I think we need also to adjust our recommendation not to be as focused on carb counting whenever we have someone that has a trouble relationship with their food. Um, and acknowledging that there's a range of carbs that are allowed. And as long as there's no nutritional deficiencies, it's also okay to be on the lower end of carbohydrate, and we may still be healthy with that. Oh, I know you wanted to add something.
Yeah, it's just about the adverse effects of uh, what otherwise are very useful technologies. And I guess that a lot of us people living with type 1 diabetes would never regret, and we never go back to finger pricks and stuff like that. But it comes with strings attached. And Jennifer in the chat mentioned the case of some of the teams that she's following. And I can only relate, thanks God that CGM did not exist when I was a teenager, because I definitely know that my parents would have been over my curves all the time. And there are some experiences that I did as a teenager that it's good that my parents were just unaware of that. There is also the issue of the body image. It's not easy, even for me at 45 years old now, to go to the gym wearing my CGM and my insulin pump for everyone to see, because that can lead to inappropriate questions. And sometimes you just want to exercise and not give a lecture on type 1 diabetes and so forth and so on. So I think it's very important that the person has the choice to switch from one way or to another. I know that some people during the summertime, for instance, they decide to go back to multiple daily injections and finger pricks because they don't want to have their disease for everyone to see. And the second thing that I wanted to underline, and I don't know whether that should have been for you, Remy, a trigger, it's the step count. Because since now all the CGM data are available on your cell phone, usually it goes through the application of your own mobile device. And that application will give you your blood glucose levels, but as well your cardiac rhythm, the number of steps you are doing every day. And for certain types, I guess the perfectionist types of people, well, you have a report at the end of the week saying, you exercised less this week than last week, which is totally, I mean, sometimes, you work, you have a grant to write, and you basically spend your week sitting on your chair. And of course, you don't do your 10,000 steps a day. And that can be stressful. And for someone with type 1 diabetes, the fact to see your curves and have some change of colors when you go above the target range, that can be something stressful just because you feel like you are failing in diabetes. So as soon as it's beginning to be a concern or something that makes the person suffer, that we need to foster a sound relationship with the technological means that we live with. They can do a lot of good. They can be problematic, as for instance, in the online community, there are sometimes some kind of contest between people about how flat my line has been during the day. But that's completely unphysiological. There is no one not living with type 1 diabetes that would achieve such a flat line in a day. So there are a lot of self-experiments, and that's totally fine. But sometimes the access to this data can lead to completely unrealistic goals. And of course, what happens with this kind of goals is that you fail and you feel like a failure, and that's a problem.
So that's a very good point to remind that even a non-person living without diabetes will never have 100% time in range. The problem is going to be, NEDIC is going to have a lot of work because those sensors now are available, at least in the US, for the general population. They are people. There is actually a French American girl who have more than 5 million followers on Instagram, which is preaching for a flat curve. So we are going to create a lot of issues. There was another issue mentioned actually is access and reimbursement and cost. It can be extremely costly when it's not covered. So you're absolutely right. Because we are close to running out of time. I see Jennifer actually has raised her hand. Yeah, you're still muted, Jennifer. Not enough experience through the
Okay.
COVID. Not enough
Can you hear me
experience
now?
through the COVID period.
Are you able to hear me now?
Yes, we are.
Okay, thanks. Thank you, Aude, and for describing some of what you experienced. I work in both the pediatric obesity clinic and the diabetes clinic, and I sometimes struggle to figure out the treatment approach that speaks to developing a healthy relationship with food and eating. Normally, I would go with developing a sense of your own cues, developing a healthy, positive relationship with eating. And we often, if it was just the eating disorder, would try to avoid the calorie counting. And like you said, the focus on the details and controlling everything. I'm just wondering if the panel has any tips on how to blend, like what we know about how to typically develop a healthy relationship with food in our bodies, while balancing this need to control and monitor everything. I find it a unique challenge.
I think we need to acknowledge that the recommendation for good clinical practice for nutrition are based on nearly nothing for type 1 diabetes. We don't have so much literature. So, the basement, the foundation is not very strong. And if we believe that patients are their own best experts, I don't see why a patient without major psychiatric issues would do bad thing for his, her health. And most of the time, we all know that this can happen. We observe through the better registry, for example, we have data now close to 5,000 people with Anne-Sophie, Sylvain, and Aude. We have the four of us working on this, that the patient with type 1 tend to eat far less carbohydrate than is usually recommended. And there is probably here a yin and a potential yang. The yin is that they see that their glucose is improving immediately. And we see this in the registry. We clearly see that the people, I'm not speaking of people making keto diet, but people tending to restrict their carbohydrate compared to the usual recommendation tend to have a far better glucose control. If I remember well, and Sophie, it's doubling the likelihood to reach the A1C target if the target, it's an essential target, but it might not be. At the opposite, we need to acknowledge that we don't know if this would increase the risk of cardiovascular disease on the long term. For example, you could raise your LDL or have a worse quality lipid profile that might be deleterious or have some liver issues with this. There is no signal at this point, but we need to be cautious around this. So sorry for my too long answer at that time. I believe we don't know a lot about nutrition in overall and specifically in type 1.
And if I may, it all depends, of course, of the person, but for some communities, there are a lot of affectivity and emotions, positive and perhaps negative, surrounding food. So perhaps a good approach is to identify with the person what are the important meals of or the period for those who are Muslim, for instance, to what extent it's important or because of ethnic background. I know that a friend of mine, she's Indian, and there is no meal without rice because that's the basis of the and so perhaps, and I would say it's the same with physical activity. You can exercise for fun or because you want to improve your health or to become an athlete and so forth. But for most of us, it's just for having fun, uh, the fun to move around. And for eating, eating is sometimes invested with meanings and values that are completely irrational and invested with a lot of health beliefs and stuff like that. um, I would suggest that, okay, what do you like to eat? Do you like to cook? What kind of food are you comfortable with eating? And what are the foods that you would like to eat, but you restrain from eating because, and it's not a all or nothing approach. You can sometimes make it up for a donut or what have you.
Sylvain, can you switch to the next slide so we just wrap up, please? And I'm a culprit of being a bit late. So for me, that patient had bulimia. I saw some people challenging this in the chat, and it's perfectly normal. I don't believe there is not a blood glucose. It's not diabetes. Psychiatric disorders is not like diabetes. You cannot diagnose this with a blood thing. So we went really for reassurance. We changed the follow-up pattern for her. We had a quick referral. And I must mention that in some cases, outside of Health Canada indication, with no endorsement neither by NEDIC, which I did not discuss with them, but I am quite sure by this, and JDRF, there are some people tremendously helped by Ozempic outside of the classical indication. In those cases, we need to better refine who is getting this or not getting this. And my point here as an endocrinologist is this should be done with the mental health team hand in hand here. There are some patients really benefiting from these drugs beyond what Elon Musk, Oprah, and so on people told about that drug, not to lose a few kilograms before you take your bath suit to the south.
Thank you. I think we will conclude on those words. Don't take for granted what Elon Musk says.
And I wonder,
Uh,
Sylvain, if you want to turn to just resources slide for people to know that it's there and we can maybe wrap up there.
Yes, it's the
and
next.
they were listed, I think, in the chat at the beginning. Were
Yes,
they?
they are.
I think they were.
And
And
sorry
please,
for those we did not answer to all the comments in the chat. I tried to follow them, but I lost some. Sorry, I apologize for this.
and please feel free to fulfill the forms in order to get any comments to improve the future webinar.
Yeah, Amanda's put a comment into the chat with
Yeah.
our anonymous feedback form. If you have a few minutes to take that and fill that out, it'll help us if you want us to continue the conversation. This part two discussion came out of people filling out that feedback form to part one that we had in December last year. If you feel like you know people in your life who are impacted by eating disorders in English, they can reach out to NEDIC. In French, they can reach out to ENAB Quebec. And as you all know very well, JDRF Canada has both information for healthcare providers as well as some specific information around mental health and type 1 diabetes. And we'll make sure to send these resources out to you as part of our post-webinar follow-up email. You'll get an email in about a week's time with the link to the recording as well. You'll also get some access to some of these resources too, but fill out that feedback form if you feel like there's more that you would like in this topic. Remy, Aude, Anne-Sophie, Sylvain, merci. Anything else you want to say before we wrap up?
I love your
Merci.
t-shirt, Ari. Good enough. It's
Thank you.
Yeah. Thank you very much for this opportunity.
Bye-bye.
Thanks, Remy.
bye.